Today we're focusing on my most memorable and best teaching case in STEMI care. A date stamp, today is the 5th of February 2021, 3 p.m. Singapore time. This APSC CME is brought to you by APSC, endorsed by the Singapore Cardiac Society, the PCI chapter, as well as the Asian Pacific Society of Interventional Cardiology in proud collaboration with Medtronic. My name is Jack. I'm your chair today, the current president of the Asian Pacific Society of Cardiology from Singapore. My co-chair today is Professor Morton Kern from the USA. It's coming to midnight for him, so I hope he can call in if he's not asleep. Our panelists today, we have Professor Ashok Seth, the current president of the Asian Pacific Society of Interventional Cardiology, APSC from India. Dr. Rosli Muhammad Ali from CVS Central Malaysia. Dr. Jimbo Hao from China. Dr. Yoshito Yamamoto from Japan. And we have 6 great presentations lined up for you with in-depth discussion after each case. Our presenters include Dr. Shozo Ishihara from Japan. He's going to talk to us about severe dissection at the LD ostium during emergent PCI. Professor Byeong-Keuk Kim from Korea. He's going to speak to us on Cath lab in the ER, emergent primary PCI in the COVID-19 era. Professor Kwan Lee from US, he's going to talk to us on a very interesting case on the stealing Stemi. I'm not too sure what it means, but you'll hear from him soon. Dr. Paul Ong from Tan Tock Seng Hospital, Singapore. He's going to wish that there were more clots for him for the Stemi case. Dr. Asri Ranga from Malaysia. His talk today is on prison break. And Dr. Cheng-Yi Xu from China. He's going to speak to us on cardiac arrest caused by Stemi and multi-coronary artery spasm. This content is copyrighted by the APSC and should not be distributed without prior permission of the APSC. The views and opinions expressed in this webinar are those of the faculty members and do not necessarily represent those of the APSC. Today, one thing that's different on the APSC Champions League is that for the participants, we're going to ask you to vote and judge for the best presenter. And the voting criteria later on the link will be based on the following criteria. Vote for who you think has the most wow and oh my God case, on the best Q&A that is answered, and what do you think is the overall best teaching case. And take note, presenters, this is how you're going to be judged later for the voting series. We also have a most valued participant, our MVP prize for today. So for those participants who type in a Q&A with good and tough and sharp questions, we're going to vote for you as well to see who will get a secret prize from us. So our faculty members will then vote for the best participant via the panelist chat. A little bit about housekeeping. The live streaming of this content is made currently available by Wonder Medicine, the APSC Facebook and YouTube pages. For Singapore registered physicians, CME point will be awarded to participants who are active for this 2-hour webinar on the Zoom meeting. This webinar is also accredited by EBAC for regional participants. You will receive your certificate of attendance upon completing a survey sent to you via email after the webinar. For the participants who are very game to ask questions and win a prize, please click in the Q&A button. I'll get my presenters also to answer to you on the Q&A later if you ask questions. A little pitch for the upcoming webinars on the 18th February, later on next week. We're going to have another webinar on the most impactful cardiovascular trials in the last decade, a review of the studies and thoughts of Professor Greg Stone. So feel free to attend the next segment for our webinar. Just to state the objective of today's focus is a fellows focus for the Cath lab, but it's really useful for the whole Cath lab team, the seniors, the nurses, the technicians, and the radiographer, because we do need the whole team to function to save a life. So we want to focus on simple and succinct advice, life-saving messages. We want to make it fun so there's no stupid questions. Please let your hair down, ask away. We also want to make sure that we have a milieu where it's honest and respectful to show that even our giants here and our champions can have their own complications. So we want to learn really from each other. So let's get started without any pause. I would like to welcome our first presenter of today, Dr. Ishihara, to speak to us on his STEMI case. So Dr. Ishihara, please. Dr. Ishihara, do you mind unmuting yourself first, sorry, and to share your presentation?
Yes, okay, thank you so much. Thank you for inviting me. So it's a great honor to join this wonderful international conference, and I'm so happy to see many famous doctors, even in this COVID era. So today I will share my case. So it's very disappointed case, but I believe it must be very educational for many doctors. Can you see my slides?
Yes, we can see. Please go ahead.
Yes,
Thanks.
okay, please, thank you. So the patient was 71 years old female, and she was admitted to our hospital in midnight due to dyspnea. Chest X-ray showed severe pulmonary edema, and ECG showed S elevation in V2. She was diagnosed acute heart failure with anteroceptor STEMI. Blood exam showed cardiac enzyme elevation and also severe acidemia. Check X-ray, we can see the severe lung edema, and also ECG showed cardiac echo showed anteroceptor severe hypokinesia, like this. So for this patient, we performed emergent and it showed so after region at proximal reality like this. So stenosis, only moderate stenosis. Poor collateral. So in this case, we performed emergency for this STEMI case. Culprit region is proximal reality, and so we choose 6 French guiding catheter. So Sion blue couldn't enter into occluded region, and even using micro catheter defines, but guide wire goes subintimal space. So that changed to moderate guide wire, so ultimate plus 3, but it also advanced false lumen. So this time, so it's a problem because I'm absent from the hospital. It's midnight, and also in this term, I was go abroad. I'm not in Japan, so that I couldn't join this emergency PCI. So that my younger colleagues, so a few doctors joined and tried to do their best, but guide wire couldn't pass the large, and also large dissection was created. Our colleagues inserted IABP and gave up the procedure. So in spite of intensive treatment after first PCI, her heart failure worsened. So that after I came back to Japan and we performed second PCI after 3 days. So this is a so second PCI geography. We can see occlusion, and also there may be so large, still remaining large hematoma, and so dissected lumen. So I choose a French guiding catheter and from a femoral approach, and even using IABP. So first guide wire, so using Sion blue, easily go into the so dissected lumen. So I tried again and again, but it is difficult to get a small true lumen. Like this, so this is advanced, but easily go to the false lumen. So in this point, I check the IBUS. So this is IBUS catheter, and we can see this is circumflex, and this is a small true lumen. So it means it's a very large dissected lumen. So how can we get this small true lumen? So in this point, rotate the IBUS image, and this is circumflex. So from areocaudal view, we are seeing from 3 o'clock this direction. So after advancing the guide wire into circumflex, and we should rotate the guide wire counterclockwise 90 degrees. So maybe we can get this small lumen. So I try this. Oh, sorry. Okay. So the wire is circumflex and a little bit rotated counterclockwise. So I feel the guide wire is advancing another lumen, so some resistance. So that I check the IBUS again. So the wire is in the small lumen like this, and wire is still false lumen, but so the second wire is into lumen. So in this point, check IBUS, change the IBUS on the so second wire. So this IBUS is in small lumen, we can confirm. So in this point, dilate small balloon, and I didn't inject a contrast because I don't want to make the hematoma and the dissected lumen more larger. So that checks IBUS again to confirm the bifurcation of LAD and diagonal branch. So this wire is advanced to diagonal branch. So after IBUS confirmation and using dual lumen catheter, so catheter, could advance the wire into the mid distal LAD like this. So after advancing the wire, open up with 2.5 balloon and check IBUS again, not injecting contrast because so I don't so to avoid the hematoma enlargement. So after that, checking IBUS and the IBUS marking, puts the resolute stent. And after putting stent, we can see the distal LAD, and put one more stent for proximal LAD like this. After stenting, angiography is very nice, and dissected lumen was so fixed very nice. So final IBUS showed very nicely open the stent. So this is a final angio. Because we could get the true lumen, we can get all septal branches and also even all diagonal branches very nicely opened. And so we can see the very nicely revascularization. So IABP was needed for 1 week after PCI, and ejection fraction was very reduced and severe LV dysfunction. But after intensive care and rehabilitation, she was discharged after 2 months. So this is the last slide. If we encounter the coronary ostial large dissection, IBUS guided guide wire control may be helpful for wire crossing to the small true lumen. To catch the true lumen, confirm the position of the guide wire and the IBUS catheter, and we should confirm which direction is the side branch, and after that we can rotate the guide wire suitable and appropriate degrees. So I know, so IVUS catheter is so limited in some countries, but this kind of serious situation, we should use IVUS. It's my final message. Thank you for your attention.
Thanks, Dr. Ishihara. Can I get Dr. Rosley to comment and ask questions on the case first? Rosley, you're muted.
Yes, please.
Sorry.
So thank you very much. That was an interesting case, as usual. And, one of the questions that was asked was, is there any specific reason for femoral access? I believe, number one, it depends on how much you're comfortable doing through the radial route. And of course, radial route, if it's possible, is safer. But I'm not sure, maybe the patient had pulmonary edema and the blood pressure may not be that good that it might be safer to actually do from the femoral access. So that will depend on the primary person who's actually doing it. Yes, IVUS would be good. One needs to know how to use IVUS confidently because you need to know how to rotate and how to visualize, and from there how to actually try to get your wire at the correct site. So that is a technique that one just has to learn if one needs to be confident about using IVUS as part of the procedure.
Dr. Hao, Dr. Jimbo Hao, any comments or questions?
Yes, I think that this is a very interesting case. And I want to ask two questions. And the first is, do you think what's the reason for the dissection? Because at the beginning, from the angio, we know the total occlusion of the proximal LAD, but the root of LAD is normal. And so the reason maybe for the big dissection is caused by the guide wire, and maybe in the first PCI procedure. Yes. And the second is the question is for this patient. I think that maybe the cardiologist will be very interested in guide wire choosing for the second time, and to you must rotate the guide wire and according to the IVUS, and what kind of guide wire you want to choose.
Yes, thank you for that question. So first question, maybe why the dissection lumen was created. So as you mentioned, it might be by the guide wire rough handling, I think. So so I mentioned I'm not in the hospital, and my colleagues, they are not so experienced, so it's a problem. And we should do very careful wiring, even STEMI case. So most of STEMI cases lead with very soft wire, but in some case, for example, very ruptured plug may cause wire crossing difficult, so that wire may go into the subintimal, so it means false lumen. So as you said, guide wire made dissection. And the your second question is which guide wire is better for the wiring? At that time, for CTO case, well, maybe the lesion is very hard and including calcified nodule or something. At that time, we need a very hard wire. But for this case is as is so STEMI case, maybe so plug is not so hard. So I choose Sion blue or Sion, or even in some situations, Sion black. And such kind of soft wire is enough for this case. And my last comment is, so maybe you and also the doctors joining in this conference is very professional. So they can solve this kind of problem. I could do, but so the younger doctors sometimes face these kind of problems. So that team level so increasing is very important. So that I want to share this case for younger doctors.
Thanks, Dr. Ishihara. There's one question from participant. Maybe Rosley can answer that. Dr. Grufam Anand asks, if you're not sure, can you actually inject contrast to a microcatheter to see whether you're inside a false channel or true lumen? Is that advisable in a STEMI situation?
Well, in STEMI, it's a bit different. You got to feel, but if you are not sure, it's my practice. I do not inject through microcatheter. Reason is because if you inject and you're not in true lumen, you'll just extend the site of dissection, and then hematoma will be more, and that will be a sign of a risk of failure. So the retrograde is, and you can see that there's retrograde flow from collaterals on the right, and that will be a much safer way of doing it. So I try to avoid as much as possible unless I'm sure that I'm in, and I just take it just to show that, as a teaching thing, but I do not advocate injecting through microcatheter.
So I think just to re-emphasize Rosley's point, if you have good collateral, just take the bullet, bite the bullet, show the collateral, so contralateral injection. If not, you should actually be able to wire through branches, whether septal or diagonal, if you're in the true lumen.
But just one point with regards to putting into the branches, and once you get into branches, you think that you're in. If you're going to use a stiff wire like a conquest wire, you find that it will go through this so-called branches and it's still not in the true lumen. So one thing that I need to admonish you. Now, if you pass through with a stiff wire, you think that in true lumen, you can change with a soft wire. And if the soft wire is in the right lumen, it will go down. If it's not, it will stop at a certain point, and it curves and stop at a certain point, then you know that you're not in the true lumen. So you've got to be very careful with stiff wire.
Thanks, Rosley. So that's a good start. We're going to move on to BK's case on STEMI in the COVID era.
Okay.
Prof Kim, please.
Okay. Okay, can you see the slide?
Yeah, we can. Please go ahead.
Okay, thanks, Jack. So it's great honor for me to make presentation here. Today's my case is very simple. So I would like to introduce our some system for the emergent procedure in the COVID era. So this is the patient history. 70-year-old male patient was transferred for the management of ongoing chest pain. The risk factor was ex-smoker. He was infected with COVID-19 from the positive contact person. Initially, there was no symptoms. However, after admissions, fever was spiking and pneumonia consolidation was suspected, and antiviral drug and nasal O2 was applied, but the symptom was not so severe. Vital sign was stable except mild fever. This is the chest X-rays. On chest X-rays, the pneumonia consolidation was suspected. And then during the hospital stay, chest pain developed, was ongoing and aggravated. As they performed the ECG, on ECG is 2-3 AVF, as still a little bit elevation was noted, and also is a cardiac enzyme was positive. And the patient's chest pain was not was very severe. So at that time is clinical diagnosis was STEMI, maybe inferior words. It's ongoing chest pain was noted. The pneumonia with coronavirus. So for the proper management, primary PCI is the transfer was planned. So the securing safety regarding the transportation and quarantine system for COVID positive patients would be more urgent. So when you look at the recent ESC guideline for patients with a STEMI with COVID infection, positive or suspected infection, is primary PCI was still recommended. On ACC/AHA guideline also is primary PCI was recommended. So this is the Korean PCI guideline under COVID-19 era, fully adopting the recommendation from ESC and ACC/AHA. Primary PCI was recommended. Based on these recommendations, we had a plan to perform the emergent STEMI patient PCI. So this is the blueprint of the emergency department of our Yonsei University health system. As you can see, there are two different entrances for ambulance and general ER patients, fully separated by each gate and with a negative pressure room each sectors like this in the figure. So our Cath room inside the emergent room was designed to improve the outcome of the patient with cardiogenic shock. Cath room was located at the entrance of ER building and between the exam room and for the new patient and intensive care unit for the CPR or unstable patient, and directly linked to the entrance to the CPR room. So as for the transportation of STEMI COVID patient, the entrance was totally separated with other gate, and patient was transported directed from the ambulance to the gate with crossing all other gates for this path. During the transportation of the COVID patient, or other procedures or other treatments will be proceeded without crossing or without blocking. So this is the video recordings, the patient path. The gate was open, and then the passing through the main entrance for ambulance patient, through the door of the new patient exam room, and leads to directly to the ECAS room. It's a very, very short course. So our team was ready to perform the CAG with PPD, and patient was transported with a negative hood. So this is the CAG. On CAGs, there was some stenosis of the LAD and L cell complex, but the flow limitation was not noted. This is the RCA angiogram. So as we can expect, as a totally occluded, the thrombotic occluded lesion was noted, and this is the culprit vessel. So the primary PCI, the procedure was very simple. So we studied procedures for wiring. So some resistance was felt initially, but successfully crossed by the just the soft wire is a run-through wire. On CAG, as a tight stenosis was noted on mid-RCA. So the after ballooning using the 2.5 semi-compliant balloons, we put the 3.0 oscilloscope stent implantation and performed the high pressure dilation up to the 20 pressure. This is the final angiograms. On final angiograms, the flow of the main RCA was good, and there was no residual stenosis, and we finished the procedure. So this is the picture of our intervention team who did a good job at that day. So this is the procedure summary, especially time interval between each timing and procedure, especially the activation to lap time is only 3 minutes, and then the final activation to balloon time is only 12 minutes. And then the finishing procedure is a transfer to the world. It also is very important. This is figure explaining the patient transfer to what out after finishing PCI, a kind of a path of the evacuation. Finishing procedures that get out of the entrance and ride the ambulance, and then take a separate dedicated elevated COVID patient to the isolated COVID building, minimizing the contact. So this is the progress note. So there was no chest pain or dyspnea after PCI. On day 7, the coronary test was negative twice, and then next day, patient was discharged with this medication. So when you look at the bird's eye view of the Yonsei University Health System Complex, so the ER building and then the cardiovascular buildings is quite apart, even those two buildings are connected underground above the ground. And then the floors of the Cath room and ER was different. So for the transfer of patient from the ER to Cath room, it takes quite a while. So take an elevator twice over the underway pathway. So dose balloon time in STEMI patient was problem, especially the activation to lap time increased because of this situation. So previously, so there have been a report evaluating the effect of the hospital design and interventional platform on the patient care, particularly during the balloon time for STEMI patients who underwent the primary PCI. The interventional platform was designed to have a direct link to the ER and intensive care unit, nearly similar concept of our Cath room. So this study showed that the new hospital design had a significant effect on immediate patient care by improving the door-to-balloon time. But the floors of ER and Cath room in these papers were different. So taking, anyways, the elevator is necessary. So our ER Cath room was designed to improve the outcome of the patient with cardiogenic shock. So the Cath room was directly linked to the CPR room and inside the emergency department. So with no need to take elevator. So especially the location is the first floor, the same floor of the entrance, new patient room, CPR room to the Cath room. So we no need to take an elevator. And Cath room is completely separate from the main ER building, and then the design to adjust and separate movement of patient. So thus, it's very easy to handle patient flow and set up the triage system. So especially the separated ER Cath room could be used for various purposes under this COVID pandemic era. All COVID infected or suspected patients, including the pediatric patients requiring invasive procedures, would be a target for this room. So for cardiovascular interventions, CAG PCI, ECMO, ABP, pericardial centesis, pacemaker insertion, some other emergent peripheral procedure, including belt procedure, and then the various fluoroscopy exam could be possible in this room. And also for the non-cardiac interventions, emergent jet procedure, a central line and insertion by the radiologist, the fluoro biopsy or catheter drainage, and cerebral angiography is also possible, and various minor operations also could be performed in this room. So, ladies and gentlemen, this is my conclusion, because the Cath room inside the emergency room, the emergent or primary PCI in the COVID-19 era. For Stemi patient with the COVID positive, the fast treatment with the primary PCI is still necessary. However, a complete quarantine response to prevent the spread to other people should be basically made. Thus, the Yonsei Cath room would be the good model for the in the current COVID eras, originally designed to reduce door-to-balloon time for STEMI and to treat cardiogenic shock effectively. And then Yonsei Cath room, Cath room is located at the entrance and first floors, linked directly to the CPR or new patient triage room inside the emergency room. So it's completely separated place from the other hospital facility. And also this room is very easy to handle patient flow and to prevent the spread of infectious disease without the need to completely shut down of other facility or other treatment modalities, and also fully extended to suspected COVID or a non-confirmed patient. And also this room could be used for other invasive procedure of the suspected COVID patient. Thank you for your attention.
Thanks, Professor Kim. Very strong presentation. We need to hear more of this sharing, actually. So I would like to ask Dr. Yamamoto for his question and comments for Prof. Kim.
In the COVID-19 era, this is very important to have the separate route and the separate room for the cath lab to separate the COVID-19 to against the ordinary patient. And your hospital has the completely good systems. And my hospital is also have the, my cath lab is fourth floor, so the a bit far from the gate of the emergency room, but we also made the separate route and the elevator only for the COVID-19 patients. And we have the separate route to the cath lab. And the cath lab, we have the 4 cath lab, but 1 cath lab for the COVID-19 in your situation. So your hospital is very, very good. But each hospital must have such a separate route and cath lab for the COVID-19 patient in this situation, I think. So congratulations for your situation.
Thank you. Thank you.
Can I hear from Dr. Hao or Dr. Shi on the China experience? Do you need a negative pressure cath lab? I think a lot of us across Asia do not like what Prof Kim has, the privilege of co-located ER cath lab, negative pressure. Well, how do you do it without negative pressure cath lab? Dr. Hao?
Yeah. Thank you so much. I think that in China, especially in our province, because I'm in the north of the China, Harbin city, and so it's very different to Japan. And so in our hospital, it is required for such kind of patient to first in ER department and for thrombolytic treatment. And after thrombolytic treatment and to monitor in the ER department, if the patient is stable and waiting for the result of COVID-19 checking result, and then after the result is negative, transfer to cath lab or the department of cardiology. But if the result is positive or suspected, and so the patient will treat it in the separated department in our hospital, especially for medication and no primary PCI. And so if the patient after the thrombolytic treatment is unstable, because such as the low blood pressure and with some arrhythmia or something like this, the patient will transferred to cath lab emergency, but the patient will be protected in separate pathway and into the cath lab, and doctors, nurses in separate cath lab room to do the primary PCI or IBP or ECMO support for such kind of patient.
So you need more facilities, I get it.
Yes, yes.
And segregated facilities.
Yes,
there is a question from the participant, Professor Koji Hasegawa would like to ask Professor Kim about, in your patient, do you think COVID-19 induced endothelial damage contributes to the RCA obstruction? And what kind of antiplatelet, or do you think anticoagulation therapy needs to be given to patient?
Yeah, so it's a very excellent question. So as I previously told you, so only my patient risk factors was ex-smoker, is a no diabetic patient, no hypertension, and also is there was no some exertion or chest pain or something, even though the on CHG was some stenosis was noted. So definitely some COVID status could affect some disease progression. So as everybody knows, anyways, the COVID is strongly affect some thrombogenesis of the blood, and also some the function of endothelium. So that would be related with especially in Asia. So we should investigate is the role of the COVID-19 in the development of STEM patients. For anticoagulation is we described the aspirin and ticagrelor therapy is 90 milligrams of BID. So as everybody can know, is aspirin and ticagrelor anyways a little bit high potency in especially in Asia patients. So no the other additional antithrombotics or like low-dose was not prescribed. However, in some case, I think in this situation, in aspirin and clopidogrel and low-dose rivaroxaban also is very good option for this kind of COVID STEM patient, in my opinion.
Thanks, Prof. So maybe if you're using and you do think some low-dose rivaroxaban 2.5 BD, there will be aspirin Plavix rather than aspirin ticagrelor as a combination. So thanks, great, good start again. We're going to move on to the third presentation with Professor Kwan Lee. Thank you very much. Talking to us about a stealing STEMI. I don't know what that means, but we'll hear about it soon.
Hi, Jack. Thank you very much for the invitation, kind invitation, the honor of participating in the Asian Pacific Society of Cardiology meeting here. This is a very interesting time. We haven't seen each other in person in a long time, but I feel like with COVID, the world is actually getting smaller because I'm spending so much time with you guys back home in Southeast Asia. So it's a real honor and privilege to be here. So this case I'm about to share here is called a stealing Stemi. It's a case that I did as a junior faculty member 8 years ago when I was still covering a small 100-bed hospital near the, just north of the Mexican border in Arizona. So even though 8 years have gone by, this was very memorable, and I thought there was some things to learn from this. Let me try and forward the slide here. Okay. So this is a 58-year-old gentleman who presents with a typical acute inferior STEMI. The patient was on no medications and a past medical history. He had had a frontal lobe cavernoma of the brain with associated spontaneous intracerebral hemorrhage and frontal lobe syndrome with seizures, which cause very disinhibited type of aggressive behavior. He was post-cavernoma resection from a year before that. And he was an active tobacco user, and with his personality problems, had also a history of IV drug use, and hence also had hepatitis C. So we took him to the Cath lab, and 8 years ago, I still hadn't joined the radial revolution yet. The US, as you all know, was a bit slow to catch up. So back then, we were still doing femoral Caths. And here you see on the left system, nothing too exciting. And we turn around on the right, and there's a typical high thrombus burden mid-RCA lesion. So it's dominant RCA. The patient, because of his frontal lobe syndrome, became very combative and agitated during the Cath. Started to try and get off the bed and fight us despite all our catheters in. So we had to paralyze him, deeply sedate him, and intubate him with mechanical ventilation. So we crossed across very easily with a standard run-through wire. And you can see that once again, there's a very high thrombus burden extending for a long section along the RCA from the mid to distal segment. This is a 20 Hertz volcano IVUS. And once again, a lot of thrombus along the entire line. Not that much atherosclerosis, just a lot of thrombus, throughout the course of the vessel. So pulling back here, and then, all right. So we use procedural anticoagulation with IV heparin and abscissimab. As you all know, abscissimab has since been discontinued in the United States, but back then we still had it. Aspiration thrombectomy was performed with an expressway RX extraction catheter, and this was also before the current recommendations on aspiration thrombectomy. Back then, we also had the Clearway RX drug delivery balloon. And as a new faculty, I was eager to try all these things. So we delivered 4 milligrams of TPA and 10 milligrams of intracoronary abscissimab directly into the thrombus via the Clearway RX drug balloon. And as you all know, this has also since fallen out of favor, and we are no longer doing this. We got a pretty nice result, and we're able to deliver because of the IVUS sizing, the vessel was 5.0 at the time, and back then there were no 5.0 drug-eluting stents. We used a 5.0 by 28 bare metal stent, and you see that there was a pretty good result from this. So post-procedurally, he did well. He was extubated the following day. His post-MI ejection fraction was 60% with mild infralateral regional wall motion abnormalities. He completed 1 month of aspirin and clopidogrel, which after a month had to be stopped after a recurrent mild intracranial bleed and a seizure. So this patient is extremely high bleeding risk. 2 months after that, he developed symptomatic bradycardia, and the dual chamber pacemaker was placed. One evening, 4 months later, he yet again presented to the ER with a recurrent inferior STEMI. There was a big sense of deja vu here. This time, recognizing him and knowing the kind of problems we were going to have with his behavior, we preemptively intubated him and took him to the Cath lab. And this is the first picture that we see now. The thing that we had missed, because on previous angiography, we never followed, we were so focused on the mid-RCA. If I go back and show you the old picture, you can see that the entire time we worked in this single view, and there was this branch which we just assumed was a was a conus branch or an atrial branch, which we never actually followed up on. So that's a teaching point to all the junior members on this call. Always follow all your arteries to completion. So here you can see that there is a coronary pulmonary fistula originating from the mid-RCA extending into the right pulmonary artery. And it also so happens to be that the recurrent STEMI is exactly at the site of this coronary pulmonary fistula, which begs the question as to whether the initial STEMI and all these problems that have been occurring here were the result of a steel phenomenon and decreased flow. Because, you know, a 5/0/28 bare metal stent with excellent IVUS results after implantation should not be thrombosing 4 months after implantation, even in a patient who's only on aspirin. So it was an arc definite LST of a 5.0/28 millimeter bare metal stent within 4 months. We used unfractionated heparin this time for anticoagulation, cutting back on the aggressiveness of our anticoagulation because of our knowledge of his intracranial bleeding. We performed aspiration thrombectomy with a 7 French export catheter, and then we did PTCA with 3x20 track balloon and reestablished TIMI3 flow. And that's the balloon going up. And this is the picture of what we have now. So the question obviously is at this point is, what are we going to do? You know, this is a very difficult patient to get onto a procedure. This is not a patient in which you can put on blood thinners for an extended portion of time. You know, do you use any of the techniques? Should you just fix it here? Should you stop, call your surgeon, your senior colleagues, etc.? You know, I think given all the thoughts, right, a covered stent would not be good in somebody who can't take Plavix or aspirin for a long time. And, you know, surgery would be an option, but being such a difficult patient, we decided that, yes, we were going to coil this on the table at the time. At that junction in time, I had never coiled an artery before. So thankfully, we had FaceTime, and I was able to FaceTime a senior colleague who walked me through exactly how to do this. So the fistula was wired with a 014 run-through wire preloaded on a 2.5 French Renegade microcatheter. We deployed 5 4x4 millimeter complex helical 18 and a 3.6 millimeter interlock coils into the fistula. The only reason for mixing the coils up is because in this small one-room hospital cath lab with no on-site CT surgery, these were all the coils that I had on the shelf at the time. The RCA was then rewired and post-dilation angioplasty was performed with a 4.0 times 12 sprinter re-establishing RCA flow. So this is the wiring of the coronary pulmonary fistula with the run-through wire. This is the Renegade microcatheter up here, and you can see the radiopaque tip. And then following deployment of all the coils, this is what you can see clearly closing up here. And we re-ballooned this segment, trying our best not to re-stent it. And this was our final result. So the clinical course, he was extubated. Clopidogrel and aspirin was continued only for 2 weeks. Then he went to aspirin monotherapy because we were able to avoid stenting. He had no recurrence and remained stable from a cardiovascular standpoint following 2 years of follow-up, although he did have multiple psychiatric admissions, and then he disappeared off the radar from our electronic medical record system. And, you know, I presume at that point he had, you know, probably died from doing something criminal or bad. But yeah, so I think the learning points from this case, some basic stuff for junior faculty, just, you know, make sure you follow all branches from all arteries when you're performing routine coronary angiography. Congenital coronary artery fistulas are uncommon, and they commonly drain into right heart structures. Most are asymptomatic, but they can be associated with coronary steel and ischemia. Options for treatment can be achieved with coil embolization, covered stents, or surgical ligation, and each of those obviously have their pros and cons. Thank you. I'm open for questions.
Thanks, Kwan. Now I know what I mean by a stealing heart. So, Paul, you have a comment or question for Kwan?
Yeah, I do. I really enjoy this case, and then really good teaching points. I say that knowing that you probably will beat me hands down on my case competition. But I'm just query, you know, we see fistula all the time, but fistula can be a benign phenomenon. It may or may not be. And I'm just thinking out of the box, which now 8 years down the line, would you consider maybe put some kind of flow wire or pressure wire down the LAD and then use a balloon to occlude that fistula on and off and see whether, you know, occluding that side branch really affect the flow or not? Would you do that?
Yeah, Paul, that's an excellent question. You mean put the flow wire down the RC and not the LAD, right? Yeah. No, I actually thought about that at the time. I think the problem there is in the setting of an acute inferior STEMI, occluding, you know, the FFR results, first of all, would not be valid because of the infarcted myocardium downstream. You get an artificially elevated FFR. It's a good thought, I think, in a stable patient. But in an acute setting like this, you know, I had to make decisions that were time sensitive because of the way the patient was behaving and the fact that every time we did a procedure on him, we had to fully intubate him, etc. I think you are right. To be able to prove that it was truly stealing would have been very elegant. But I think under the conditions, there was not much to explain why exactly a 5/0/28, where you had excellent results just 4 months ago, would re-STEMI in exactly the spot at which the coronary pulmonary fistula was originating. And so at that juncture, I think you have to ask yourselves, even if you found that to be true, would you not believe that there was a chance that this was the cause of the reocclusion? You know.
Does Dr. Yamamoto has any comments for this case?
Yeah. Actually, yes. Maybe if there is a time, we must have this the confirmation about this still artery is the cause of the RCA occlusion. But maybe, as the Dr. Lee said, that this case has several complicated problems. So the FFR may be the good procedure, but maybe you cannot do that. But yes, I think that. But this maybe. Before the occlusion of this artery, maybe you can use some other technique like another what can I say? But several ways to prove the of this situation, is this stealing origin or not? But I think.
We could possibly have done a QPQS calculation. I think that should not be affected by the FFR, you know, by the setting. That could have worked.
Yes, I think so. Yeah.
Any comments from Rossley? What are your thoughts? Do you have a call this?
I think it's interesting situation. There are two things. Firstly, I felt that the first MI is a plug rupture, and you know it's congenital. And you can have chest pain ischemia, but an infarct with coronary artery fistula, I think, to me, I've not seen one. I don't think it's likely. But on the other hand, when you put in the stent and you have a steal phenomenon, there is a possibility that it might be linked. And with regards to treatment, I would have done the same thing like what you did, Kwan. The only different thing is I would actually be interested to find out what is the cause for the second infarction, and probably an IVUS will be good to see whether there's actually a plaque rupture or not. But I would go on and seal off the fistula. I would probably be a bit more tempted to also put in the stent for the second one. But firstly, as I said, it's probably not linked, but it's a possibility that it's linked for the second one.
Yeah, no, I totally agree with you. I think the first one was just a straightforward run-of-the-mill plaque rupture, STEMI. And I think, you know, that 5/0/28, you know, with the steel up there and the flow turbulence and healing, etc., it must have caused some issues. Thank you for those comments.
Any other thoughts or questions from the other presenters or panelists?
What is interesting is also he seems to have had a pacemaker done in bradycardia, you know. So whether that was also related to that. And that's interesting. And in the past, I had a few cases, one or two, but not in acute setting. And the FFR really made you can see the change in the FFR after coiling and before. You know, I did my first case was almost 10 years ago, and there was an eye opener. And then you can actually use a flow wire to gauge, but not in maybe the acute setting. Maybe it's a bit different because QPQS will take time. And I know you only had one opportunity at this guy. You will not get him on the table again. Good job.
Thank you.
So I think the participants provided good feedback also. I think most participants also pointed to the fact about the Brady episode, whether there was already some restenosis then. And
Yes.
also, I think most people prefer a stage procedure and some form of elucidation of whether this is related. So I think very interesting case. So we're going to move on to the next one. And Paul is going to speak to us, wishing he had more clots, I think, for Stemi.
Thanks. Okay, let me share my screen first. I really, looking at the cases that are already presented, I'm kind of a bit embarrassed because this case is going to be a lot more straightforward. But here we go. And I also have to, credit my fellow consultant, Dr. Randolo, for helping me to prepare the PowerPoints. So it's a 70-year-old gentleman with a background history of hyperlipidemia, really had nothing particular in terms of risk factors otherwise. And he came in with severe acute onset chest pain, and the ECG diagnosis was a Stemi, and you can see the highly sensitive troponin was off the chart. That's the ECG. I don't think there's a lot of doubt what's going on. So we carried out an angiogram, which sort of brought the patient to the Cath lab, transradial approach. We had a look at the right coronary artery and then moved straight to the guider. A very standard antiplatelet regime, aspirin plus ticagrelor up front, and as heparin was given at 100 units per kilograms. So that's the angiogram. No prize for guessing that there's LAD which is involved, but it's also a lesion in the circumflex as well. RCA small, non-dominant. Okay, so moving swiftly, we went on and performed the PCI to the LAD. So you can see that my colleagues sort of, why the LAD quickly ballooned. And of course, once you open up, you notice that the diagonal also have some problems. So you also went on and used a small balloon to tease open the diagonal as well. So this is the results. Okay, so LAD, is back, which is nice. Diagonal, smallish, heavily diseased, but, probably need to do something about it. I'm happy to discuss that. IVUS was carried out for both the LAD and the circumflex for sizing purpose. So after that, and a bit of manipulation, they went ahead and stented the mid-circumflex, and that's the result of the circumflex. I thought it looks pretty good. And I think they did the circumflex first because just in case the LAD stents came a bit close to the ostium or just in the left main, there may be, easier to get the circumflex out of the way first in case, if you do the LAD, it might make things a little bit more difficult. So I thought this is all going quite well at this point. Those who know our lab practice, you're probably aware that we are, sorry, let me see if I can, I have a little bit of problem. Okay, I beg your pardon, but I might have to just restart my PowerPoint. It's very untimely, sorry about that.
No, it's a PowerPoint complication.
Yeah, okay,
So,
so let me go again, okay? So just bear with me, a sec. Okay. I think I'm going to be somewhere here. Okay, you are not, I'm not sharing screen yet, right? So let me.
No, you're not.
Yeah, I just need to go back to Zoom and go to share screen. Okay, bear with me. It's a complication forum, so these things tend to happen. Okay, you should be able to see my screen now, right?
Yep.
Okay, thanks, Jack. Let me go back to slideshow. Okay, so the circumflex been done, and they went ahead and did a drug-coated balloon to the diagonal. Okay, Holbert diagonal and DEB'd it. Then after that, we stented the LAD. So far, so good. Okay, and then the pot's been done for the LAD. But then the flow in the diagonal gone down. And some of you might argue that well, the diagonal is not the largest in the world. But because they actually spent a bit of time and effort and DB'd it and et cetera, they decided to rewire and retrieve that diagonal back. And this is where the trouble is, because it proved to be really difficult. And from what I gathered, they used multiple wires and even using a supercross. They changed wires multiple times. And in the process, the wires are parked in LED and moved back to the diagonal, et cetera, et cetera. But luckily, they eventually managed to recross into the diagonal with a Pilot 50 wire. Okay, so this is what it looks like. Patients start getting a bit more chest pain. Hemodynamic is stable. Okay, so those with sharp eyes will probably already seen and noticed there's a distal LAD perforation. I wasn't very sure why doing a diagonal when I'm perforating the LAD, but from what I gathered, the wire really, there were multiple wires in and out. So I think they might have parked the pilot wire in the LAD and try another wire and then swap things around. And this is what happened. So immediately what we did was we looked for some clot, and that's hence the title of the talk. We thought if there's an MI case, then we aspirated some clot, we can stick the clot down. But whatever clot we got out, there wasn't really enough for us to do that. So we took some more blood, stuck in the side, and meanwhile we inflated a small balloon distally and hoped to seal it. Okay, but this, doing that and multiple times and waited for almost 10 minutes, there was just no thrombus to be formed. And I think not surprisingly, because the patient has DAPT and on full dose heparin. We were thinking of coiling, but the coil that we had in the lab were a little bit too small, and we were actually going very distal. So we can't get clot. So at that point in time, we couldn't seal it with balloon. Then it's left with just either thinking of putting some foam gel, or maybe we'll put a coil, put some fat tissue in. But of course, Jack, I was extremely envious that you had a session on distal perforation. I missed that one. But this is what we use instead. Okay, we use a plug, and I'm not sure those of you are familiar with this device. So again, you put a microcatheter down, remove the microcatheter. Okay, and now you deploy the microvascular plug over the wire catheter. So once you put it in, you can check angio to make sure it's sealed. You can give it a tuck to make sure it's secure. And then you just detach it. And at any point you're not happy, you can recapture it. Okay, so that's what we did. So you can see that, the device actually looks quite long. You can see that this is the device at the more or less at the apex. Okay, this is the microcatheter tip. So the device is already put in, and you can see that we're testing angio, and we can see that the clot, the dice basically contrast held up here and no longer any further. And then here is probably not the best captured scene, but you can see that we deployed it, we unscrewed it and just left it behind. And this is what it looks like. check angio, no leak anymore. And then afterwards, we took a long time to optimize the stand, make it all look nice. And this is the final result. So a quick word for those who are not familiar with it. I mean, the device comes in different sizes. The one that we used was the smallest of the smallest, the MVP size 3. Size 3 because it can close up to 3 mm. But actually, the best bit about it, it can close vessels from 1.5 to 3 mm. So really very suitable for distal perforation. And these are the model number. But I think the MVP3 is the one that needs to be used. The microcatheter is a little bit larger than the one that we normally used in CTO. You need someone with a lumen a little bit bigger, internal lumen of 0.021. Kwan, this device would be really suitable for the case in your RCA earlier. So here, my conclusion. I think we need to be careful, and I think all of us need to have bird's eye view of where the distal wires are, and this is particularly true for the fellows. And I think, you know, if you are using CTO wires and all hydrophilic wires, this is particularly the case. You must not lose sight of where the distal wire positions are. As far as we're concerned, there has been no written case report describing the use of microvascular plug in such usage. There are some advantages in that this device is extremely easy to use, very rapid in deploying it, and you can place it optimally because if you're not happy, you can resheath it and reposition it until you're absolutely sure before you detach it. And this may actually be a more reliable and secure alternative to treat distal wire perforation. Okay, thank you very much for your attention.
So thanks, Paul. Again, very good presentation. Can I ask a panel who has experience in doing a distal perforation using an MVP device? Anyone? Dr. Ishihara.
Yes. So in Japan, it's not available. So we always use coils, and in some situation we use part embolization or thrombus embolization. But so this is very, I feel it's very useful. So how do you choose coil and also this plug for distal perforation?
Okay, that was a good question. I'm sure the coil will work here too. But you know, we have this device in our lab for a little bit. I think, you know, this device is probably available in Japan. It's a common device interventional radiologists use. They use it.
I see.
Probably worth finding out whether it's in your interventional radiologist stock. But you know, the issue of coil is very distal, and that the coil that we have, the 3 mm coil, so we're not really sure it will be particularly useful. This microvascular plug is really, really easy to use.
Easy.
Get out to doing it. The whole thing took about 2-3 minutes. And it's so secure because once you put it in, you can test it via the microcatheter as well. So you can be sure that it's working. You can tuck it to make sure it's secure. You've done all this and you're happy, then you unscrew it. And then after that, because it's so secure distally, my fellow consultant took another half an hour to do all kind of things to the LAD and imaging and make sure everything is okay before we finish the case. And throughout, we didn't have to touch the heparin.
So,
it's a really
Paul,
nice way to have.
Thanks for that. A tip from Kenneth Chin from Malaysia, actually, in the participants gallery, he says that he usually draw out 10 mils of blood before you give heparin for complex PCI or CTO, and this is ready-made clots. So if you wish for more clots, you can pre-plan the clots. And he also suggested gel form. So I guess there are a lot of stuff you can shoot down to do this occlusion. Any other comments for Paul? Yeah. Yes, Rosley?
Yeah. I think number one is to remind people that when you have a distal wire perforation, the likelihood of it sealing by itself is going to be, not very high. It means you see that you're going to have a flow which is continuous, and the chance of tamponade is much higher than. So I would suggest that if you have distal perforation, you have to treat it, and not just say, oh no, it will close off and seal off and leave it behind. It will probably not. And there are multiple ways, as some of the people have said. I tend to use FET if I don't have coils. One of the things that Paul mentioned is that his coils are too big, and it's very important because if you have not a right size coil, as you put in, this coil tends to elongate, and therefore the area that is going to be affected is much higher, and you may actually cause a much an area of infarction. The other thing that some people, and I've sometimes think about it, is sometimes you can use distal tip wire. If you cut it and you push it right until the end and try to coil it, it may or may not work, and that's a so-called a slightly cheaper way of using like a coil, the distal tip of wire that you cut and try to push it in. But one needs to be very careful as you push in, obviously, and you just want to seal at the distal end.
Yes, Dr. Hao, you have a comment?
Yes. I think that because in China we don't have such kind of plug, but for this very distal perforation, and in our case lab, we sometimes use the microcaster very distal to LED and to give the gelatin granulates, and so you can just push, mix the granulates gelatin into with the contrast, and then bolus into the microcaster. For maybe 5 cases of patient last year, we use such kind of method, and so with a good result.
That's also a very good tip. So I think we'll just quickly summarize this case for the fellow. Strong points from Rossley. Usually wire perforation, when you miss it, actually that's more common. Then a few hours later is usually not immediate. They come with tamponade. And then you find that you have to sort it out. And the second bit is that I think you can throw a lot of stuff down, appropriate size coil, clots, gel foam, or what Dr. Ishihara, there's always some fat for you to find in the puncture site to inject. So all good strong points actually. So thanks for that. We're going to move on to the next case with Asri presenting to us his prison break case. So Asri, thanks.
Hi, hope you guys can hear me. I'll try and start sharing. Can you see my slides?
It's coming on, I think. We can hear you very clearly. Yep, go ahead.
Okay. Sorry. So I'm from a public hospital in KL, Malaysia. This is my hospital. So the topic of my case today is prison break. Okay, it's an honor to be presenting more experts. And this is my new building. You're supposed to come up with 6 cath labs, but I think because of COVID, it's been delayed.
Asri, we are seeing your slide deck, not the full screen. Maybe you can switch your display setting. Just switch your display setting.
Sorry.
Just swap your display view if you can. If you cannot, we are happy to just look at the screen if it still works.
Okay, let me see. Can you see it now?
No, I think you probably have to swap your display setting if you're using dual monitors.
Okay, let me try again.
Yeah, just swap. Yeah, just do the swap presenter view.
Okay, how is it now?
You probably still have to swap. Oh yeah, now it's okay. Let's try this.
Okay, sorry. Okay, this is my. Can you see now the slides are moving?
Yep.
Yep.
Okay, so no conflict of interest to declare. And so basically, mine is a much more simpler case line. So it's a memorable case because it's a 50-year-old prisoner referred from one of the periphery, our spoke hospital. We had the Stemi network. He had dyslipidemia before. He had a bypass done in 2006 in another state. He had a previous myocardial infarction. So he had chest pain in the prison at 10 a.m. And he was quickly rushed to the nearest hospital, which was not our hospital. It was 10 kilometers away. And there he was loaded with the APT. And at that time, the examination, he was pretty good. His blood pressure was high, but saturation was okay. This was an ECG, but sorry about this, but this is the only tracing we had from that hospital. And you can see there was ST elevation in his inferior leads with reciprocal changes in one AVL. So this was the ECG. So that hospital is about 10 kilometers away. And usually, you know, from the prison, there's always delay in transport and so on. But this patient was quickly brought into the hospital. He arrived within about 50 minutes of having chest pain from a prison, which I think is fast enough. And he arrived in our cath lab about half an hour later after arrival from Kajang Hospital. So it was within 30 minutes. Within 5 minutes, we managed to puncture him, and aspiration was done within 10 minutes. So the door to balloon time was 67 minutes. But what I like to show you is basically what I did was looking at his ECG and so on. We made a deduction that it must be the RCA, either the native or the graph itself. So we straight away went with the 6 French system, right femoral, 6 French GR4 guiding. So we didn't waste time looking for the left and so on. So this was a native, which was actually proximal RCA CTO. And here we can see that the SVG was occluded. So we don't usually come across SVG STEMIs per se. And in the past, when we always say occluded SVG, there's no point opening up and things like that, but that's maybe in the chronic setting. So here we can see a column of dye, which was like, scintillating up and down in the SVG to RCA. So we straight away, although, there are a lot of things which the usually we don't say, you can't do, like opening SVG graph, we did. And the other thing we did is immediately we put in a export catheter, a 6 French export aspiration guide. Although we say in STEMI nowadays, use less, there's not much evidence for it, but we know that in SVG there'll be a lot of thrombus, and we actually did multiple aspiration. And what surprised us in this case was it was actually red clots coming out, despite people saying in SVG it's more of debris and things like that. So red clots were coming out, and I think we did aspiration for maybe 10 or 12 runs basically before we actually took a shot. And we were actually amazed and surprised. The whole artery just opened up, and it's actually a tight, very tight distal lesion just before the anastomotic site, very tight lesion there. So maybe luck was on our side and things like that, and things were moving quite quickly. Patient's chest pain dissipated. So at that time, we pre-dilated distally with a balloon. Of course, we always say, trying to put in a distal protection device, but here it was very distal. So there's no landing zone for the distal protection device. So for me, in that way, it was a bit more interesting. And what happened was after POBA, there was no flow again. So in view of a lot of red clots coming out, we decided to actually give GP2B3A inhibitors. Although trials have shown in SVG it doesn't work, but I think it should be case-to-case basis here. And then, so this is after, so what we did is, we at that point, this was about just after Leaders Free trial came out, and we were worried this guy is a prisoner. So at that time, the only stand with 1 month DAPT in this group was actually biofreedom. So we decided to put a 3.5 biofreedom distally, worried that this guy as a prisoner might not be able to take, DAPT in the future. So, so we went up, it looks quite big, and we post-dilated. So everything went on quite quickly. And these are the final results. There's some disease before the actual stent, but we just spot stented at distal area, and a patient actually did very well. And after this, we actually did not even bother to go and look for his left-sided system and things like that, because ours is a public hospital. We have a busy 30 patients waiting in the queue. So what we decided is straight away, we'll settle the issue. We will actually do a cardiac CT later on to look at his lima to LAD and so on. So that's where we stopped. His PCI was done, his ST is resolved. It was quite fast, the screening time and so on. We did continuous ReoPro infusion. Maybe there was no need for it, and we planned for MSCT. And this is his STs. There was some T-wave inversion, and there's very small Q-wave forming. So we managed to deal with it quite quickly. His EF post-procedure was 52%. It was discharged well on day 5. He was reviewed 2 months later, no angina. MSCT done later revealed a pattern SVG to OM, lima to LAD, and the SVG to RCA was also pattern. So basically, we don't come across a lot of SVG STEMIs, but graft disease can occur in few phases, early within 1 month, maybe thrombosis, 1 month to 1 year intimal hyperplasia, and more than that, you can get atherosclerotic lesions. So most common cause of ischemia is atherosclerotic plaque in this group of patients, although it is a vein graft, okay? But there's little studies or evidence of what is the best treatment for this group of patients when they do have an acute MI in SVG. We know that embolic distal protection device is useful in this group of patients, but most of these devices have been outdated. The SAFER trial, we don't have percusage. Maybe we only have easy filter now, Spider EX and so on, but also it depends on the landing zone. Like in this case, you need at least 30 millimeters from the distal edge to land your distal protection here. You cannot use a distal protection device. And a lot of adjunctive pharmacology has been studied, and multiple agents have been shown to reverse flow, as you can see in giving adenosine, diltiazem, verapamil, but these are all small short studies. And GP2B3 inhibitors have not been shown to be beneficial in PCI, in SVG grafts, but this case, I like to point out, is an exception. And I think it actually helped to restore flow given the mechanism. And one of the clues was when we aspirated, we actually got a lot of red thrombus coming out. And so in this short presentation, STEMI in SVG is rare. So primary PCI versus thrombolytic therapy, evidence is lacking actually even for primary, but of course, most of the time we try to go in with the primary PCI, and distal protection device is recommended. GP2B3 inhibitors not been shown to be beneficial, but I believe it's case by case basis in STEMI. So that concludes my presentation. Thank you.
Thanks, Asri. So maybe I can call for comments from Rosley first. Rosley, have any comments?
Yeah. Now, I mean, that was a great case. There are a number of things that I think. Firstly, with regards to GP2B3A, and I think that's in general PCI to SVGs, there's not been shown to be useful. But in this case, there's lots of red thrombus and we've shown it, and acute MI, and I feel that it would be useful, and as what you found. So I would agree with you in terms of using the GP2B3A. Secondly, with regards to distal protection device, you have correctly pointed out it's too distal. I would not, and it's fairly discreet, I would not think about wanting to use it. You can see that distal vessels are small anyway, and it's not, you can't pack it, and even if you're able to pack it more distal, you need at least a 2 centimeter distance away from the device for you to be able to put in your devices like a balloon and stent. So I would just go ahead and just balloon and stent as what you did. But there's nothing much different from what you have done that I would done differently. Well done, Asri.
Dr. Yamamoto, any comments?
Yeah, we have some filter device, special device capable with the microcatheter. So in Japan, we're using the microcatheter into the SVG, and we will do the distal angiogram with the microcatheter. Then we are putting the filter device through the microcatheter, and then we are using the balloon or something, and aspiration, and then maybe we in the SVG STEMI case, we need some GP3A or something, and we do not have such a drug in Japan. So maybe the urokinase using the perfusion catheter. Then maybe if the flow is good, then we will remove the full system, and after using the urokinase or something in 2 or 3 days, then we will study the angiogram, and that's using the stent or something if there is no more thrombus. With such a way is good, I think. Then what do you think about the course?
Thanks, Dr. Yamamoto. Kwan, you have a comment?
No, but I'd just like to share that, I think this statement about not doing STEMIs of SVGs is not quite correct. Over the years, we've done a lot of SVG STEMIs that have subsequently stayed open for many, many years. I think it really depends on the speed at which you get to it. We do try and get as much clot out as possible. That seems to have worked. Sometimes it comes out in big lumps when you aspirate. And I think when it comes out as a more organized thrombus, you tend to get a much better result. So yeah, I think we should still do SVG STEMIs. I'm not quite comfortable with the move towards doing the CTO of the native vessel. I think if the native vessel is not a CTO, then for sure you pick that over the SVG. But when you have a CTO to choose from versus an acute ST elevation STEMI, you should go for the STEMI.
Paul?
I agree with what Kwan said fully. And same thing, I think we are just a little bit behind in terms of seeing the bypass patients coming back with this type of problems, simply because surgery was less well perceived in this part of the world. So we have, we're a little bit behind in the volumes of those patients coming back. I recall when I was in the UK, roughly about 1/3 of my cases are bypass restudies. I think in America, I'm sure you're seeing the same. And I think we will see the same thing in Malaysia, in Singapore as well. So it's inevitable that you will start seeing more and more STEMI patients coming because of vein graft occlusion and all that. And I think, yes, if it is the native, it's suitable to be done, great. If not, and a lot of time it's not, then I think the thing is probably easier and quicker to get the patient out of trouble and PCI the vein graft. And, it's a lovely case that you did, Asri.
I just like to ask the panel, there are some studies which say that you can undersize the stent in an SVG, which I don't do, but I try to match the size, but you can undersize the stent in SVG and yet you get comparable results. Any comments, especially Dr. Rosli?
Yeah, I think Gus Pritchard actually did a number of work on this group of patients, and he published. And what you need to do is, you don't want to be oversizing it, because if, let's say, there's lots of glue and it's a friable SVG, especially a long SVG, then you might have a more likelihood of distal embolization. And what he felt was you can just use a smaller stent and get enough to actually get the flow and at least to be safe without having to deal with distal embolization as a complication.
Another thing which is not talked about much is how about imaging in SVG? Anybody has experience like, you do image?
I had 2 days ago, middle of the night, 5 o'clock in the morning, came in, 2 vein grafts, both compromised. So wire them, IVUS it, direct stent, and because you have IVUS, you know exactly where you want. Put a stent which is half a size smaller and go really high pressure and make sure it's well deployed, and that's it. Not chase it, not post-dilate it, and interrupt it as little as possible.
Yeah, I think Paul's points are excellent. We also do a lot of IVUS and OCT imaging of grafts, but the main thing when you say undersized, that does not mean malopposed, right? Undersized must mean opposed, just not aggressively pushed size towards the EEL.
Any other comments from the panel?
Probably just one other. If we always think that the SVG sometimes is because it's being SVG, the plaque is actually soft. It's not entirely true. You can have the same atherosclerotic plaque and it can be fibrotic. So I had a case that was 2 days ago, and it was a fibrotic plaque. You can see it because when you balloon it, it doesn't open very well. And in that case, we use a cutting balloon, of course, slightly undersize it, and then we put in the stent and went very high pressure. So do not think that it's a soft plaque all the way, because in the end, what you have to do is that you need to have a stent which is well expanded and well opposed. And that's very important, because otherwise the risk of thrombus will be very high.
Dr. Hao?
Yes, in our hospital, and we really just performed many cases of OCT examination for SVG, and the stenosis, most cases is atherosclerosis plaque, and so it's just a mixed one, and not all lipid one, and so with the some in condition with the calcium calcification. And so we will use OCT to decide how to pre-dilate such kind of plaque. If it is a soft one, and direct stenting. If it is hard one, and so pre-dilated with cutting balloon or just such kind of pre-treatment. But I think that with OCT examination, we should choose the suitable size of the stent, but not with too much high pressure, and so to prevent the no-reflow.
Thank you. Thank you. Thanks, Asli. I think that was a very nice case because it's actually a few things. One is that I felt that there are circumstances when there's a lot of clot burden, you can have simultaneous infarction. So I'll be more comfortable in shooting everywhere because sometimes you can have more than one site that can occlude in a STEMI situation. We have seen that before. Second bit, really, STEMI in graft cases are not really that rare. Probably you're going to catch it more and more sooner or later. It's not uncommon actually. And I like the points about saying that the under-deployed stent coming out from the Washington Heart series, they say it's undersized and it's actually not under opposed. So it's still a good way to do it. For the protection devices, I think like there are distal and proximal protection devices. I think in a lot of cases, if the pharmacotherapy is done well, probably don't need it. Dr. Yamamoto mentioned maybe a deferred approach with some thrombolysis if there's truly a lot of clot burden. Because sometimes when you do stented, they have a lot of distal embolization. Covered stents and all these are probably run out of favor in graft cases as well. Just keep it simple, keep it safe, and restore flow. I'm surprised Paul didn't mention drug-eluting balloon. I don't know whether he's a strong proponent of that, but that's a story for another day. So we're going to move on to the last case of the day before we vote, and Dr. Shi is going to share with us STEMI, shock, and arrest. Dr. Shi, please.
So, can you see my slide?
Yes, full screen, please. Thank you. It's good.
Okay. And dear President of the committee, dear friends online, it's my honor to accept the invitation of the conference. I will give the case presentation, cardiac arrest caused by STEMI and multivessel coronary artery spasm. I hope my case can give some reference for clinical work. Maybe this case was published on the American Journal of the Emergency Medicine. The case presentation, a 64-year-old man with the chief complaint, intermittent chest pain for 10 days. And the characteristic of the chest pain was described as almost nocturnal onset, also can be caused by large activity during the daytime. The steady risk, including hypertension, smoking, and the laboratory test showed the troponin I 0.073, a little higher. We give the chief admission diagnosis unstable angina. The ECG shows anterior leads V1 to V4T wave inversion. And the echo may be low special. And ad hoc PCI was arranged the next day after the admission, but just on the day of ad hoc PCI, the patient was told that his procedure was stopped because of the positive fecal occult blood. And then the patient was in an excitable state. Unfortunately, cardiac arrest onset after emotional agitation. And what we did at that time, we repeat defibrillation, continued CPR, and in a short time, he was given mechanical ventilation and IBP insertion. Anti-arrhythmic drugs were also given, and large dose of vasoconstrictor drugs, including dopamine and adrenaline, norepinephrine, was also injected repeatedly. Fortunately, after timely treatment, the patient's conditions stabilized, we repeat ECG immediately. The result showed extensive anterior leads V1 to V6 segment elevated the T wave upright. You can see from the slide. What should we do next? The answer must be emergency CAG. And after CAG, maybe the interventional therapy, maybe if necessary. We did emergency. You can see the emergency CAG, the circumflex and the right coronary artery was slender, and the proximal LAD was occluded. We see again. What happened with such patient is the image of coronary artery spasm. If spasm, what's the cause of spasm? And Stemi itself, vasoconstrictor drugs, or both or others. It should be pointed out that the patient's condition was very bad during the angiography. ECG monitoring shows ventricular escape rhythm. The heart rate about 50, and the blood pressure maybe lower than 70, under the support of IBP and the large dose of vasoconstrictor drugs. What should you do after CAG? Do you want to continue the procedure using intracoronary nitroglycerin, open the LAD, or end the procedure? Afterward, the hemodynamic was unstable and the coronary artery was thin. We believe that at that time, the LAD had to be open, and otherwise the prognosis of the patient was dangerous. And the effect of the coronary spasm needs to be ruled out first before revascularization. If we continue, we must maintain the stability of the circulation. IBP was ineffective to significant refractory hypertension. Continuous CPR using Lucas prior to ECMO implantation. After ECMO implantation, we use NTG 200 intracoronary was used before the LAD angiography again. Maybe the Lucas, maybe just 26 minutes later, the ECMO was successfully implantation. What happened? And let's see what happened after the NTG-IC. The vessels become loose. Maybe the circumflex normal. And the borderline lesion, just we can see the proximal LAD, just borderline lesion here. What's the cause of spasm? So we can't help to ask, what's the cause of the spasm? We thought maybe there were many reasons, including physiological stress, inflammatory factors release, but most important, using large dose of vasoactive drugs after cardiac arrest maybe is the main cause of the spasm. The same thing happened in the RCA. There was severe stenosis here in the middle of the RCA. We do the OCT. We use OCT to find out the cause for proximal LAD occlusion. The OCT result showed proximal LAD plaque rupture and local thrombosis. Maybe it's so quick we can see the maybe here. And the proximal LAD plaque rupture was caused the Stemi just after the Stemi happened. The vessel recognized itself, and then many factors caused the muscle vessel coronary artery spasm, especially the proximal LAD occlusive spasm. According to the finding of the OCT, we put a stand Firehawk 3.0 18 to the proximal LAD and do the post dilation. Use the balloon 3.5. Maybe it's the last the final imaging. We also do the OCT just after the standing. We did the PCI. We did the PCI for the right coronary, right coronary artery. Use the dense Firehawk 3.5 26. This is the final imaging. We removed the ventilator the next day, and 3 days later, we removed ECMO. IBB withdrawal maybe just 6 days after procedure. 3 months follow-up after primary PCI, the patient with no symptom, the echo shows the left ventricular diameter maybe 4.6, the left ventricular ejection fraction 50%. And that's the take-home message. Once the Stemi patients have indication for the primary PCI, we must overcome all difficulties to open the IRA. Vasoactive drugs can cause severe coronary spasm. Mechanical circulation assist, including IBP, ECMO, Lucas, maybe Impala, can be our strong backing up. Thank you.
Thank you, Dr. Shi. Extremely interesting case. Can I ask for some comments from the faculty? Rosalie, I'll start with you first again, sorry.
I've seen it in 2 cases. Where there's spasm and we had to resuscitate, but we just put an IBP. Once we engage, we give nitroglycerin, actually open up the blood vessels. So this is something that has always been in my mind, that once you resuscitate the patient, you're giving a lot of inotropes, you might actually be seeing these cases of this. Not common, because most of the other cases that you resuscitate, you find that there is no vasoconstriction. So it is an uncommon phenomenon, but something that needs to be thought of.
Kwan, you have a comment?
Yeah, I've seen this several times, especially with vasopressin, amongst others. I've seen it with dopamine, norepinephrine, etc. where you get this diffuse severe vasoconstriction. And unfortunately, once that starts to occur, you end up with this very bad spiral that you go downstream. You have to administer intracoronary vasodilators. And I don't just use nitroglycerin. Usually I follow that with nicardipine as well, because nitroglycerin is very short acting. And then you find yourself stuck in that position while the patient is recovering from cardiogenic shock, where you're very hypotensive and still you need to maintain perfusion. So I've never been able to get out of it without using adjunctive and mechanical circulatory support. IABPs have worked before. I've had to also upsize to Impella while we get past this. And also we've also used ECMO to try and get out of these situations. But once you start that spiral, given the fact that you have to stop the vasopressors, give the vasodilators, and in that bridge period, you have to use something. And I think in Asia, the most realistic thing obviously is an intra-aortic balloon pump.
Any other comments from the faculty for this case? Any comments? BK, do you have any comments?
Maybe in Japan, many doctors may be using both the vasodilator and the vasoactive drug, noradrenaline or something simultaneously in this situation, and with the IABP. That will help to stabilize the situation, I think.
So with no further comments, I thought I want to congratulate this one as a wonderful save. And again, diffuse coronary spasm causing post-collapse with vasoconstrictors is not uncommon, like what Kwan said. And it's rarely you can get them out without hemodynamic supporting them and yet vasodilating them. So this is a very uncommon situation where you handle with care. What I found works quite well is that after a hemodynamic support, you can deliver more selective vasodilator through a microcatheter or thrombectomy catheter. And I find that in this, unfortunately, you have to give very strong vasodilator to relieve it. So I find that nitropruxide works quite well as well. Intracoronary nitropruxide is a bit longer acting, is a bit more potent than just nitroglycerin, and a combination of even verapamil, intracoronary, adenosine, GTN, but I favor nitropruxide. So, and then at the meantime, hemodynamics supporting them. If they have reversal, identifying a couple relation like what I did and stenting them is a good bailout. So thanks a lot. I think we're coming to an hour, so I want to move on to this phase of it, which is a voting exercise. So in the chat box, you'll find that there's a link for you to go in and vote. So can I request for the participants, the faculty, go to the chat box and get into the voting now. So I'm going to do my voting as well. So I'm going to go to my chat and then go to the link and spend 1-2 minutes submitting a vote. Remember, we have very strong cases here, and vote for the 3 criteria. Oh my God, the best teaching case and the best Q&A answer. So vote for the highest rank for each operator and presenter. Thanks a lot. I'm just going to do my voting, choose my favorite case as well. So feel free to do so now.
So, Professor Jack,
Yes.
Can I continue a little bit? So, discussion.
Yes, please.
So last case.
Continue the discussion while
yes.
people are voting.
Yes.
Yep.
So for last case, so as you mentioned, nitroprusside is very effective for very strong spasm, but in some countries or in some hospitals, doctors are not so used to use nitroprusside. And so even in my hospital, so senior doctors get easy to use, but young doctors don't know how much dose they should use for intracoronary. So that it is important to share the dose in the hospital or in the countries which dose is better. So it's very important to share such kind of information.
So nitroprusside, you have to be careful because people are not used to it. So you have to dilute it properly, and it's 100 micrograms actually.
Yes.
So after you draw it out, you have to dilute 1 mil into 10 mils again. And then you
Yes.
dilute further to just give 1 mil out of the 10 mils.
Yes.
Just like verapamil or the rest of the drugs, you can't give the whole dose. It's 100 micrograms. You give the whole dose,
we should be careful. Yes, we should be careful to give intracoronary. Yes.
I'm
The
just
the nice thing about nitroprusside is it's very short acting, like nitroglycerin, when it's given in that form. So nitroglycerin, nitroprusside, very short acting. You know, while verapamil, nicardipine, etc., tend to last longer. So you know, you can always back off if you've given too much.
Jack, can you put out the names again, Jack? Because I can't remember the.
Yes, of course. Yeah, so sorry about that. Yeah. So just to go through, we have a dissection case by Dr. Ishihara at the left main ostium, how to build out acute Stemi with wire dissection. That was very nicely done. BK did a completely different slant sharing on, it was actually complex in how a simple Stemi becomes complicated in the COVID time. So I love that one too. Kwan did an unusual case of a Steving Stemi. And Paul did build out using an MVP plug that I didn't even know existed from Medtronic. So distal wire perforation, he wished he had more clots. Asri talked about a prison break. It was a case of a prisoner who came in with graft STEMI or RCA that he treated very nicely. And Dr. Shi showed a coronary vessel spasm that precipitated cardiogenic shock, needed a bailout with ECMO and vasodilator treatment. So these are the 6 cases. And you saw in the chat box actually, the link in the chat box to vote. So Sam, are we ready to announce the winners?
Another minute, please.
Okay. So maybe we can go around again to discuss some of the cases. You saw some of the cases here. Any other clarification or comments? BK, you've been quiet. I wanted to ask you actually just now. I thought I didn't have time. I saw that in your COVID case, there's this bubble wrapping around them when you push them around. You mean the cases had to have some casing when they are transported? Is that correct, or is that what I'm seeing? They have this plastic wrap around patients.
Yes, it's a hood type is bad. Is a negative pressure was applied. So actually, it's some designated COVID hospital has that kind of hood. So the reason why the some activation time is reduced. So actually, the some negative hood bed is applied. It just go in. The open the door and close the door, it's enough. So and no need to some cleaning of some path of the patient. So although we perform some cleaning process after procedure. So anyways, the negative hood would be very important one.
Wow, that's very interesting. I didn't know you can put patient in a negative pressure bag into a negative pressure cath lab.
Yeah.
So, and then you don't have to clean that much after that. Okay, that's very interesting as well. I don't know if I'm a claustrophobic patient, I'll be miserable, but okay, that's something interesting. But it was wonderful what you shared about your cath lab and the workflow environment in Yonsei Hospital. Sam, are we okay? Sorry, they have to line up, get the votes and line up so you can announce it.
So Jack, in the US, in the US, we're one of the highest COVID infection rates in the world. We've kept our primary PCI program open throughout the time. We have 4 cath labs in my hospital. We converted one of it into a negative pressure room. What Dr. BK showed us from Korea is remarkable. For us, we haven't done that at all. We've just put masks on the patients, even the ones that are COVID positive, and transported them through common corridors. We found that basically mask and face shields That's what most of us use while we work, even on COVID positive patients. And I have to say the rate of work acquired COVID is very, very low in the 1 year that we have kind of sat through this pandemic. We've had up to 150 patients with COVID at a time in my 400-bed hospital, and probably 20 or 30 cases of work-associated COVID acquisition in a year. So, that's the cheaper version of doing it. But we should not be the model of how things are done, for sure.
I'm not sure. Hopefully things will look up post. You have a new president, I see. So let's see. Okay, Sam, are we done? We're 5 minutes to the end. We do need to collate.
Yes,
Okay, so I'm going to stop share for you to. So I don't know who the winner is. Our secretary is going to tell us based on the poll. So we're going to announce our most valued attendee first, those who provide the best feedback and chat so far. So let's have the drum roll then. Sam, you're ready for that? So our most valued participant for today will be okay, so Dr. Anand Gufran from Pakistan, I think is our very enthusiastic participant. He also dialed into our fellows training course last week, provided very good feedback this round again. So let's move on to our winners for the presenters award. So we're going to announce one winner and 5 runner-ups. So our first runner-up would be okay. So let me look at the faces. First runner-up would be Dr. Ishihara, Dr. Paul Ong, Dr. BK Kim, Dr. Asri, and Dr. Shi. So I can't remember who's not on this list now. So the winner for today, next slide, please. Okay. Kwan, looks like you stole our heart too. Kwan, thanks a lot.
Congratulations.
For showing us the most wild case, best Q&A, and best teaching case. So Kwan, thanks and congratulations. But I really appreciate everyone's presentation for today. And Rosley, you want to have a final parting words before we close?
Okay. Once again, firstly, I think the presentation, it was good. There's some, I've learned a lot from it, even though some of the cases I've encountered myself. But what is important is the approach that you've had in treating those cases. And some of it, for example, from Paul, that's a device I never knew existed. I know it's a vesical plug, but I didn't know that there was a microvesical plug. So things that I learned at the same time. And I believe with what we had, what do we have? We had about 228 people attendees. That shows that, Jack, that this is something which is a winning formula, something that people are interested in listening to. And I think that's an important point in trying to make education which is available, something which is practical and people would like to learn from these programs. So I must congratulate you and the team for having it done, and Sam behind the scene. And I hope we will continue to have this and a lot of people joining in to learn and share their experience. So thank you very much. And I really enjoyed this session. Jack?
Thanks, Rosley. Yeah. Yes, someone wanted to say something else, sorry. If not, I just, in the last minute, we'll come to the end of the session. I would like to thank all the participants and of course, all my presenters, and you all deserve a prize, which will let you know soon what the prize is. Everyone is a winner here. I would like to thank my moderators, Dr. Yamamoto, as well as Dr. Hao, and as well as Professor Rossley as well. So great comments, everyone, and we to help create this very educational session, which is currently live streamed and it will be stored for video on demand for anyone who's interested. So there will be, usually our uptake is about 20,000 participants who view this webinar post-event as well. So we hope that we can continue to share this information across the Asia Pacific. So with that, I'd like to thank everyone. Hope you get your vaccine very soon, and please keep safe during this period of a pandemic. Thank you very much.
Bye. Good night.
Goodbye.
Bye.
Thank you.
Bye. Good job, Jack. Bye.
Thank you. Bye.
Yeah, take care, everyone. Bye.
Congrats, Kwan.
Thanks, Asri. Yeah, no, we should have I learned so much from all the rest of everybody.
It's time for you to sleep now.